that will prevent movement in 50% of subjects in response to pain. And this is a very useful parameter in clinical practice because it helps us determine the concentration of gas to administer to the patient in order to achieve the desired anesthetic effect. So each inhaled anesthetic has its own MAC, and those that have a low MAC require a low gas concentration to put the patient to sleep for surgery. Drugs with a low MAC have a high potency. In contrast, drugs with a high MAC require a high gas concentration to achieve an anesthetic effect. These are low potency drugs. So because the MAC of a drug describes its potency, MAC is going to be related to lipid solubility. But unlike the oil-gas partition coefficient, where the higher the coefficient, the higher the lipid solubility, in the case of MAC it's an inverse relationship. So drugs that have a very high lipid solubility have a very low MAC, and vice versa. So here is a table with the same gases we talked about 2 slides ago, but instead of just showing the oil-gas partition coefficient, I've added the MAC. And so you could see that halothane, which had a very high oil-gas partition coefficient, meaning that it's a very potent and lipid-soluble gas, has a very low MAC. In contrast, nitrous oxide, which was not very lipid-soluble and had a low oil-gas partition coefficient, nitrous oxide has a very high MAC. Even if you administer 100% nitrous oxide to a patient, you won't be able to achieve no response to pain in 50% of subjects. So one of the reasons it's nice to use the MAC is because it helps us understand what concentration of drug to give to the patient. But another nice thing about describing inhaled anesthetics by their MAC is that the properties are additive if you decide to use 2 drugs together. Sometimes one of the inhaled anesthetics like sevoflurane will be mixed with nitrous oxide. This allows you to use a lower concentration of each drug, and when you do this, the MACs of the 2 drugs are additive. So for example, if we used a concentration of sevoflurane equal to half a MAC, instead of anesthetizing 50% of patients, it would only anesthetize 25% because we're using half a MAC. But if we then added nitrous oxide in a concentration equal to half of its MAC, that would give us another 25% efficacy, and then the two 25% would add together, and the combination would be equal to 1 MAC with 50% efficacy. And so sometimes drugs like sevoflurane are mixed with nitrous oxide because it allows the patient to be exposed to less of each drug and lowers the risk of adverse effects. And when you mix drugs like this, the MACs will be additive. A couple of special things to know about the minimum alveolar concentration for inhaled anesthetics. The MAC decreases with age. It also decreases in pregnancy and hypothyroidism. So if an anesthesiologist is trying to put an older man to sleep, like this man shown in the picture here, they might use a lower concentration of drug than they would otherwise use in a younger healthy person, and that's because the MAC for persons in this man's age group is going to be lower than it is for younger subjects. So here's a summary slide of the important properties of inhaled anesthetics. The onset of action and the washout of an inhaled anesthetic is related to the blood gas partition coefficient. The higher the coefficient, the slower the onset of action and the slower the washout. This all ties back to the solubility of the gas in blood. The more soluble the gas is in blood, the slower the onset and the slower the washout. Potency is different. Potency is related to the oil-gas partition coefficient. The higher the coefficient, the more potent the gas is. This is all related to the solubility of the gas in lipids. Drugs that are more soluble in lipids are more potent. And then remember that we talk about potency in terms of the MAC. The lower the MAC, the more potent the gas is for putting people to sleep. There are certain physiologic effects that are common to all of the inhaled anesthetics to some degree, so let's talk about those now. The first one is respiratory depression. When patients are administered these inhaled drugs, they will have a lower tidal volume and their CO2 will begin to rise. And so for this reason, usually these drugs are administered to patients who are intubated and on mechanical ventilation while they are under anesthesia. The inhaled anesthetics can also cause myocardial depression, which can reduce the cardiac output, although this effect is minimal with the 2 drugs sevoflurane and isoflurane, which are the ones that are commonly used in modern practice because they don't depress myocardial function. So that's a nice segue into talking about the most commonly used inhaled general anesthetics. The 3 drugs you most commonly will see used in anesthesia in the United States are desflurane, isoflurane, and sevoflurane, and that's because these 3 drugs have the least adverse effects and the lowest rate of myocardial depression. One other inhaled anesthetic that you will sometimes see used is nitrous oxide. As we've already talked about, it has a low potency, and you can't deliver more than 0.75 MAC. Even if you give a patient 100% nitrous oxide, that still won't be enough anesthetic to render 50% of patients insensitive to pain. But the benefit of nitrous oxide is that it has a very rapid onset and offset. So one thing anesthesiologists will sometimes do is switch to this gas towards the end of a case because it will allow patients to wake up more quickly. Nitrous oxide is also sometimes used in dental offices, that's what's shown on the screen here, where you don't need to completely put patients to sleep, but you want to render them less sensitive to pain for dental work. One thing to know, however, is that when patients are given nitrous oxide, it does frequently cause nausea and vomiting in the post-op period. Another thing to know about nitrous oxide is that it diffuses very rapidly into air spaces and will increase the volume. So for this reason, you can't use it when patients have pneumothorax or abdominal distension from air in the abdomen. If you look at this drawing on the screen of a pneumothorax, there's air in the pleural space, and that air is made up of oxygen and nitrogen. So if you give a patient with a pneumothorax nitrous oxide, there's no nitrous oxide in the pleural space. So nitrous oxide will quickly leave the bloodstream and begin to fill the pleural space, and that will expand the pneumothorax. The same thing can happen when patients have abdominal distension from air in the abdomen. Some of the inhaled anesthetics have special adverse effects, which we'll talk about now. These drugs are not commonly used in the United States in modern practice. The first one is halothane. You can remember the H in halothane is for hepatotoxicity. There are rare life-threatening cases of liver toxicity in response to halothane. In a small number of patients, it can trigger massive necrosis in the liver with very high AST and ALT. For this reason and other reasons, halothane is not used in the United States, but it's still sometimes used outside the U.S. in resource-poor settings where halothane is the only general anesthetic available. Methoxyflurane causes nephrotoxicity. It has renal toxic metabolites, and you can remember that the M, which comes right before N in the alphabet, is for nephrotoxicity. And then lastly, enflurane can cause seizures. It's famous for lowering the seizure threshold. In the video on postoperative complications, I talk in detail about malignant hyperthermia, but let's briefly review this here. Malignant hyperthermia is a dangerous reaction to certain drugs used as part of anesthesia. It's been associated with many of the inhaled anesthetics. It's often described in association with halothane, but it can occur in association with other inhaled drugs as well. Besides the inhaled drugs, malignant hyperthermia can also happen in response to succinylcholine, which is a paralytic agent that I talk about in another video. Malignant hyperthermia can occur during surgery or shortly after surgery, and it presents as fever and muscle rigidity. The underlying pathology of malignant hyperthermia is diffuse muscle damage, so patients can develop rhabdomyolysis with elevated creatine kinase and hyperkalemia. They can also develop tachycardia and hypertension. So this condition is often recognized when patients develop fever and muscle rigidity along with tachycardia and hypertension either during surgery or shortly after. The muscle rigidity can make the patient hard to ventilate, and that's often one of the signs during surgery that trigger an investigation for malignant hyperthermia. The treatment is to stop the offending drug, administer oxygen because the rigid muscles can impair ventilation, and then dantrolene is a muscle relaxant which can stop the muscle damage and reverse some of the features of hyperthermia. And once again, I talk about this in detail in the video on postoperative complications. I'll finish this video by talking about the stages of anesthesia. You can break down anesthesia into an induction stage, a maintenance stage, and an emergent stage. In the induction stage, we use drugs to put the patient to sleep. Usually these are intravenous drugs like propofol, sometimes together with an opioid like fentanyl. In the modern era, inhaled drugs are very rarely ever used to induce anesthesia. They used to be used decades ago, but now that we have effective intravenous drugs, those are usually injected into a vein to quickly put the patient to sleep. Once the patient is asleep from an intravenous drug, an anesthesiologist will often administer a paralytic agent so that the patient can be paralyzed and more easily intubated and placed on mechanical ventilation. Because remember, many of these anesthesia drugs cause respiratory depression, so usually patients need to be intubated and mechanically ventilated while they are under anesthesia. During the maintenance phase, drugs are administered to keep the patient asleep. This is when inhaled anesthetics are sometimes used, although intravenous drugs can also be used, or sometimes a combination of inhaled and intravenous drugs are used. Sometimes there's also ongoing use of paralytics during the maintenance phase. The maintenance phase depends heavily on the surgery. For quick operations, there may be no maintenance drugs necessary. For very long operations, lots of maintenance drugs will be needed. And then the emergence phase is when the patient emerges from anesthesia. This is when anesthetics are discontinued. Reversal of neuromuscular blockade is sometimes done. The patient is allowed to wake up and eventually extubated. And that concludes our module on general anesthesia.